Good afternoon, everyone, and welcome to the 15th episode of our Medical Education Clinical Reasoning program. We're pleased to meet you all again, and we hope that you're enjoying our series so far. Let's start this episode by introducing our panelists for today. Today's resident is Dr. Abdullah, and our two case discussants are Maitha Abdullah and Fatma. We'll use this time to allow our speakers to briefly introduce themselves, and then we'll start with the episode. We can start the introduction with you, Dr. Abdullah.
Hello, good afternoon. My name is Dr. Abdullah, and I am an internal medicine resident in SKMC. I'm glad to join you for this episode today.
Hi, good morning. My name is Maitha Abdullah. I'm a fifth-year medical student in the College of Medicine and Health Sciences, and I'm also pleased to be here today.
Hi everyone, I'm Fatma Alia. I'm a third-year medical student from RAC Medical and Health Science University. Thank you for having me here.
Thank you all for this introduction. I'd like to use this opportunity to remind our audience to leave their comments and questions in the chat box for us to address them later on. With that, let's leave the floor to Dr. Abdullah as he walks us through today's case. Dr. Abdullah, you can start.
Okay, so we have let's start with the case. So we have a 43 years old male who presented today. Yeah, okay. So we have can you hear me?
Yes, Dr. Abdullah, we can hear you.
Hello, can you hear me?
Dr. Abdullah, we can hear you.
Yeah, just give me a second because the connection might be not very good here. So just okay. So we have a 43 years old male who presented to the ED with 1 week history of hemoptysis or cutting blood. So Fatma, Maitha, any one of you. So tell me what questions, how would you approach that chief complaint?
Okay, so the first thing I'd like to know is when he says he's coughing up blood, how much blood is he coughing up? Yani a teaspoon in the past 24 hours, a teaspoon, a cup, some small streaks.
So he doesn't really know how much blood, but yeah. So he would tell you that it's yeah. Okay, so that's a very important point. Why is that important? Sorry, this is Mita or Fatma?
This is Maitha.
Okay. So so why this is important? What would that how would that affect the investigation and the treatment, the amount of blood he cut?
It could give us an idea of what the cause is. So if it's a large amount of blood, it could be some sort of foreign body that caused rupture, or it could be rupture of some lung. Or
Guys, I cannot really hear you very well. I think I have a problem.
Yes, I think there's a lag.
Dr. Abdullah, if you can just log out and join us, because I think you're facing technical issues. Maybe you can join us again using the same link.
Okay, So how about okay, no problem.
Okay, we'll just give Dr. Abdullah a few minutes to log in again.
Hello?
Yes, doctor, we can hear you. Can you hear us clearly?
Okay. Yes. Okay. Sorry about that. Okay, so we have a patient with came with hemoptysis, and Meta said that the first thing we need to ask is about the amount of blood. Okay, so how does that help us? Because if the patient had a very huge amount of blood, he's coughing, he's losing a lot of blood, then that is a critical patient. Sometimes patients can go into hypovolemic shock just because of losing a lot of amount of blood. So that's very important, because that would decide who should take over in the management of this patient. If the patient is in shock or pre-shock state, then the patient needs a critical area like ICU or high dependency unit. However, if the patient had a very small amount of blood, coughing small amount or streaks of blood, which is the most common, then that patient can be managed as outpatient or maybe in a regular ward. So, okay, so the patient, this case, the patient tells you that he coughs like a streaks of blood, very small amount of blood that he noticed mixed with the sputum. So what other things you would like to ask?
If this is the first time this has occurred, or has it occurred before?
No, this is the first time. Since 1 week.
In this 1 week, how many episodes has he had?
So it's around 7 to 10. When he coughs a lot, he gets that hemoptysis. He gets that blood.
So it occurs with increased force of coughing.
Yeah. Okay, so you asked about if it's the first time or it had occurred before. Why is that important? Because there are some conditions which would present, which are chronic conditions that can that can relapse, and when they do relapse, when they exacerbate, they cause hemoptysis. So what conditions that present in such way?
Tuberculosis?
No, TB will present with, so the patient will have the infection, he's gonna have the hemoptysis while he's having the active infection. But for example, patients with bronchiectasis, those patients, they don't have hemoptysis all the time. They have hemoptysis when they have bronchiectasis exacerbation. So when they have an active infection, they get hemoptysis. When that infection clears, the hemoptysis clears. But then when they relapse again, they have hemoptysis again. So this is a very important question to ask, whether the patient had hemoptysis for the first time in his life, or this has been recurrent with him, because that can tell you that there is a chronic illness that is there and that is causing hemoptysis when there is a trigger, when there is an exacerbation. So what other things beside bronchiectasis, chronic conditions that can give you hemoptysis in relapsing remitting fashion?
Can cystic fibrosis?
Cystic fibrosis, what else?
Some vasculitis, or maybe
Exactly. Which type of vasculitis?
there's Wagner's vasculitis.
Okay, so that's the old name. What is the new name for Wagner's?
Granulomatous with polyangiitis.
Granulomatosis with polyangiitis. That's correct. So please don't learn Wagner, don't learn Church-Strauss syndrome. Learn them with the new names. Granulomatosis with polyangiitis, that's the correct name, okay? Because Wagner will just confuse you. Now they don't use that name anymore. Okay, what other things? What other vasculitis conditions that can give you hemoptysis other than granulomatosis with polyangiitis? Two more.
Goodpasture syndrome?
Exactly, Goodpasture syndrome. This syndrome occurs in which type of disease? What is the name of the vasculitis? Which antibody against what?
The basement membrane?
Yeah. So anti-glomerular basement membrane syndrome, anti-GBM. So that is a condition where you have antibodies targeting the basement membrane of the kidney. So when that condition gives you a pulmonary component or affects the lungs, this called Goodpasture syndrome. If that condition just affected the kidney without affecting the lungs, we don't call it Goodpasture. Okay. So to be the safe side, always say anti-GBM syndrome. The other things is, the last one is eosinophilic granulomatosis with polyangiitis, which is Church-Strauss, also can give you hemoptysis. So with that being said, so if you think about vasculitis, the vasculitis usually affects the lungs and almost all of them affects the kidneys. So one of the most important questions to ask when you evaluate a patient with hemoptysis is something related to the kidney. What would you ask?
Perhaps hematuria?
Exactly. So you need to ask about the urine. Has there any change in the color of the urine and the amount of the urine? That can tell you a bit more about the cause if there was a new hematuria associated with hemoptysis. Okay. So what other questions you would like to ask this patient?
How about chronic cough? Does he suffer from a chronic cough?
No.
Okay. He had one.
He had like the cough with the hemoptysis around 1 to 2 weeks ago.
Okay. He mentioned that it was small streaks of blood. So is it blood mixed with phlegm?
Yes.
Is the phlegm clear, or it's white, or it's colored?
It's yellowish in color.
Yellow.
Okay. How do you know that if the blood is coming from the lungs?
It might not be. It could be from the GI. So should we ask about stool?
Yeah, you need to ask about things that would point to GI causes, which are what things you would ask to make sure that the patient does not have hematemesis.
I could ask about melena, if he's noticed any change in stool color.
Exactly. What else?
I could ask about the color of the blood.
Okay, so tell me more about that.
Is it fresh, bright blood, or is it darker?
Yeah. What would that indicate? If it was fresh, bright blood, in contrast to black colored blood, which one is which? Which one is hemoptysis? Which one is hematemesis?
If it's fresh, bright blood, it's more likely to be hemoptysis. However, if it's darker colored blood, that means it's coming from a bit lower down. So that could be hematemesis.
Exactly. And also, one of the most important questions that you would ask in the past medical history is if you have any history of any cirrhosis or any ulcer bleeding before. That can tell you if the patient is predisposed to having hematemesis or hemoptysis. So if a cirrhotic patient coming up and telling me that I'm coughing up blood, I would immediately presume that this is a hematemesis, and I would look more for that instead of assuming that it's hemoptysis. Okay. Other things you need to ask about are symptoms of that are related to GI. For example, nausea and vomiting. The patient has nausea or vomiting that with blood coming out from the mouth, that will indicate hematemesis. Okay, so again, what more questions you would like to ask in the HPI?
Okay, how about has he noticed? So first, was it fresh blood in this patient? Was it bright red blood?
Yeah.
It was. Okay. Has the patient noticed any bleeding from anywhere else, the nose or the gums?
Okay, that's a very good question. Because tell me, why do you ask that?
Because it could be a coagulopathy. Maybe he's just predisposed to easy bleeding.
Exactly. That's a very nice point. So which patients are more predisposed? Give me a category of patients that are coagulopathic.
So it could be either patients who are hereditary or patients on certain drugs. So
Which
either
drugs?
patients. So it could be warfarin or heparin patients.
Yeah, exactly. We see this. I see this all the time, and when I do nights, the nurse calls me a patient who is coughing blood. So when I see the medications, I see them in heparin. So usually you don't do anything unless if it's large quantity, then you need to stop it or maybe reverse it in some cases. So that's a very important question. So the first step when you evaluate hemoptysis is to make sure that it's hemoptysis. So you need to ask about, you need to rule out hematemesis, or you need to rule out upper respiratory tract bleeding. For example, epistaxis or posterior pharyngeal bleeding. That you would rule out through the physical examination. But those are the first things you need to do before evaluating the patient with hemoptysis. Okay, so you asked about if it's the first time, you asked about the color of the blood, you asked about if the patient is bleeding from anywhere else. What other questions you need to ask to know the cause of the hemoptysis?
What about weight loss, fatigue?
He has constitutional symptoms of fatigue, night sweats, and weight loss for the past 1 to 2 weeks.
Should I ask about travel history now, or should I wait?
Yeah, you can ask about travel history. Usually we ask about travel history and sick contact in the history of present illness if you suspect an infection or travel associated disease. So the patient did not travel. He has been here in the UAE for the past 14 years, and he's not exposed to anybody who has traveled before or traveled recently.
Okay.
So why is that important again? So which infections that are important you would think of in patients with travel history?
Tuberculosis.
Okay, so TB in the US, because tuberculosis is not very common in the US, you need to ask about travel history because that's important, and that's something that would direct you towards diagnosing tuberculosis. But here in the UAE, tuberculosis is very common. So having not traveled, that does not help you in ruling out, or that does not make tuberculosis less likely. Okay. There are other infections that are associated with travel. So a patient who traveled to China or West or South Asia, maybe Thailand, he came after eating something, and then they came with hemoptysis. They come with hemoptysis. So do you know which infection is that? So that's a USMLE question, maybe.
Any of the hemorrhagic fevers?
No, hemorrhagic fevers, they will come with other symptoms, very high fever, and then they come bleeding from the gums and otherwhere. They have like bloody secretions everywhere, not just coughing. So there is a specific infection.
Is it a parasite?
Yeah, I think it is. It's a fluke.
I remember the liver fluke, but I don't think is it C. senescens?
No. Okay. So in patients who usually they go into Thailand or China, so that's the thing that would point toward the infection, and they eat raw crabs, or they eat raw crayfish. I don't know what is that. So when they have those patients will have are more predisposed to have something called Paragomnus westermani. I hope I pronounce it right. Paragomnus westermani. It's the lung fluke. It can lead to hemoptysis. So that's a USMLE question. When you get that in the exam, just think about this. So you typically have a patient who had eaten a raw fish, a raw crab coming from China. So think about lung fluke. Okay. So other questions you need to ask, which are if the patient had any sick contact to a patient with TB. So patients here, they know TB because it's very well known infection among patients from India and other Asian countries. They know the infection very well. So you need to ask them, have you been in contact with any patient who is known to have TB? As well as you need to ask about other conditions, which are, for example, if the patient had fever, if he has any simple infection, any simple pneumonia can cause hemoptysis as well, or any simple bronchitis. Okay, let's move on through the case. So past medical history, past surgical history. This patient is healthy. He has no surgical or medical conditions before. He is not on any medication. He does not have any allergy. His family are well. He is a smoker. So he smokes around so he smokes around 1.5 packets daily for 20 years. So how much pack year history is this? Can somebody calculate? For 20 years. Maitha, Fatma?
Is it a 30 pack history?
Yes. So you multiply 1.5 times 20, and that number is going to be the pack history, the pack year history. So this is 30 years pack year history of smoking. So he's a heavy smoker. So now let's go to the physical examination. So how would you start? So you start with the vitals. Okay. So I'll give you the vitals. His temperature is 37.2. His heart rate is 84. Respiratory rate is 14. Saturating 96 in room air. Blood pressure is 153/98. So you didn't hear? Okay, so I'll repeat them again. So heart rate is 84. Respiratory rate is 14. Saturation is 96. And temperature is 37.2. Okay, so Fatima, how would you start examining this patient? So what would you do first? Take me through the examination.
Do you begin with checking with the mouth and then go?
Yeah, so you start with general examination. You see the patient, how does he look? Is he tachypneic? Is he tired? Is he talking? Is he unconscious? So you start with a general examination in every physical examination. So this patient was lying in bed, very comfortable. He's alert, oriented. He can speak to you. He can talk to you. No problems at all. So the patient is stable clinically. Then you go, then what would you do? So you have the patient lying in bed. What would you do?
Do you check the face, the eyes, the color of the eyes, if there's any
Yeah.
change in the sclera, if there's any yellowish
Okay.
color and all that?
Okay. So we want to do a targeted physical examination here. So tell me what things you would look for and why. Okay. So why do you look for jaundice in a patient with hemoptysis? So jaundice has nothing really to do with hemoptysis. I cannot really find a connection. So you wouldn't look for jaundice, you would look for pallor. So if the patient is pale, that can tell you that the patient has been bleeding for quite some time. Okay, so that's what you look in the eyes in this patient. So you would look in the mouth. Why you need to see the mouth? Because you want to rule out what something we said earlier, something you need to roll out during physical examination.
That it's a coagulopathy, Annie. So there's bleeding from the gums and whatnot.
Yeah, and even posterior laryngeal bleeds. You can see them if you when you open the mouth, you can see if the posterior uh, oral cavity has some bleeding on it or not, or if there's any visible clear bleeding. You can see that can usually is the cause of bleeding in some patients. Okay, so that's really the examination of the mouth and the face. Then you go to the cardiovascular examination. So what things you would look for and why in relation to hemoptysis? If you don't think that's the examination is important, just tell me that this examination is not important in evaluation in a patient with hemoptysis. So would you do cardiovascular examination in this patient?
I've read somewhere that mitral valve prolapse can cause pink frothy sputum that can be confused with hemoptysis. So mine, it wouldn't hurt to just to check to see if there's any murmurs or.
Exactly. So what? Okay, now we have three valvular conditions that can cause hemoptysis. So what are they?
Mitral valve prolapse, atrial
Not
valve.
prolapse. Prolapse in itself, it won't cause, but prolapse associated with mitral regurg.
Okay.
Yeah. So mitral regurgitation, one of the causes of hemoptysis, because mitral regurgitation will dilate the left atrium. The left atrium, when it dilates, it will add some back pressure on the pulmonary veins. That will cause hemoptysis, as well as the mitral regurgitation. The other vascular condition is mitral stenosis. So mitral regurgitation, mitral stenosis, they cause hemoptysis. And the third condition is very rare, but it can cause hemoptysis, tricuspid endocarditis. So if you have an endocarditis affecting the tricuspid valve, that vegetation can septate and go to can embolize and go through the pulmonary artery, affecting the lung vasculature and causing hemoptysis. Okay, so pulmonary artery, tricuspid endocarditis, mitral regurgitation, and mitral stenosis. So you need to hear the murmurs of those three. Look for them when you do a physical examination. Other cardiovascular condition that can cause hemoptysis is what? Give me things. Some condition that will present with split of S2.
Hypertension.
which type of hypertension? Is it systemic hypertension?
Is it diastolic hypertension?
It's a hypertension
I'm not
connected to
sure.
which artery? Pulmonary artery hypertension.
Pul-
So pulmonary
yeah.
hypertension, those patients, they present with hemoptysis or pink 40 sputum, which can be confused with hemoptysis. So think about pulmonary hypertension as well. The last thing that you need to make sure that the patient does not have, the last couple of things that you need to look for in the physical examination is you need to look for cardiovascular, if the patient has pulmonary edema. So if you have a signs and symptoms of signs of heart failure, for example, displaced PMI, heaves, or the patient has additional heart sound S3. So those things will tell you that the patient might have a heart failure. So heart failure can give you pulmonary edema. Pulmonary edema can give you hemoptysis. Okay, so you need to think about that as well. So that is basically the cardiovascular examination. Then you go for respiratory examination. So what things in the respiratory examination that can help you like determine the cause of hemoptysis?
So first, I'd like to check for any clubbing.
Yeah, why?
Because that could suggest lung cancer or some sort of
Exactly. Clubbing, if there was a lung cancer, that will present with clubbing. Also, some cases, for example, sarcoidosis can present with clubbing, and that can give you, in some patients, hemoptysis. But lung cancer is definitely one of the most important causes you need to rule out. Other things you would do, or you need to check in while doing a chest exam is if there's any element of infection. So what would you listen in patients with infection? What would you hear in patients who have infection in the lung or pneumonia?
Crocos.
Yeah.
Rub.
So yeah, exactly. So you need to look for crackles to make sure that the patient does not have any infection. Okay, so that's and also if sometimes if the patient has isolated wheezes in the lung, that can tell you that the patient might have a foreign body. So in this patient, the patient has a completely normal respiratory examination. What other things you need to do? Which other examination you would do? Would you do GI and neurological examination in patients with hemoptysis?
I mean, if I was worried about emboli, fat emboli, I could check for, neural changes, but I don't think in this patient it's very likely.
Which emboli you think about?
Fat emboli can present with the neurohemoptysis and a rash, right? Neurological changes.
I'm not sure about that, but okay. That's but usually fat embolism usually occurs when a patient has an accident or usually in a setting of trauma, post-trauma. I wouldn't even think about that in this patient, but that's definitely one of the things that you need to you would look for in patients with hemoptysis, new onset hemoptysis post-trauma or post-surgery. Then that's definitely something you need to look for. So now you have this patient, you have the symptoms, you have the history. What investigations you would like to do?
An X-ray?
Okay, so whenever you have someone asking you what investigations you would like to do, you start with the blood, then you go to the imaging. So what blood investigations you would like to do and why would you do them?
We would do an ESR to check if there's any infections. If there's change in the ESR could show some kind of infections.
Okay, so ESR, CRP, they will tell you about if there's an, they will tell you about, there are an acute phase reactants. So they will tell you if the patient has any inflammation or not. So if the patient has an infection or inflammation, those things will be high. Okay, but they are not very specific. So CRP can be high in million causes. Okay, so you will do ESR, CRP. I agree with that. What other things you would like to do?
So we'd like to get a CBC, check the hemoglobin and hematocrit, check see if there's any, anemia from the bleeding, from the blood loss.
Yeah, exactly. And what other things in the CBC?
And then also like the white blood count with differentials to see if there's any infection, underlying infection.
Yeah, and the last thing, platelets.
Yes, platelet count.
Why platelets?
Because in coagulopathy, yes, in certain coagulopathies, or if he's tendency to bleed, it could be because of a low platelet count.
Yeah, exactly. So thrombocytopenia can give you hemoptysis or predisposes the patient doing hemoptysis. So that one of the things that you need to rule out and using a CBC. So the CBC of this patient was completely normal. Okay, you don't worry about the number, just know that it's normal. Okay, what other things you would do? The CRP is mildly elevated. ESR was not done, but it will be elevated. What other things you would do? You would do the urea and electrolytes, because those things will tell you. You need to know a couple of things. First of all, you need to know the creatinine, because you need to have a baseline for this patient. That will tell you the baseline kidney function. That will manage how much treatment. It is very important in every patient that is admitted to have a baseline creatinine, because every drug has a different dosing according to the kidney function. As well as you need to look for hyponatremia, because remember, this patient might have a lung etiology or lung infection or a lung pathology. Now, any disease that affects the lung can give you syndrome of inappropriate ADH, and that will give you hyponatremia. So you need to look at the sodium as well. Okay. So this patient, the electrolytes were normal. Creatinine was normal. Everybody, all the electrolytes were normal. Okay. So what other things you would do?
Liver function and coagulation profile.
Yeah, coagulation definitely, because the patient might be coagulopathic. Liver function, why?
Because what if there is a chance it's still hemoptysis and he doesn't know? Could be some sort of liver disease.
Okay, so even in case of hematemesis, if, for example, if this patient was a cirrhotic patient, the AST and ALT might be very low, because in cirrhosis in terminal patients, those levels will be normal. But in that patient, exactly that patient, you need to do the liver function test, because you are going to treat. If this patient was a TB patient, you don't know yet. If this patient was a TB patient, you're gonna use some medications to treat it, and some of those medications, they can cause liver injury. So you need to have a baseline liver function test. Okay.
Yes.
Okay, so let's move to the imaging. Which imaging you would do? You will start with what? You have a CT, you have a CT with angiography, you have a CT-PE, you have a X-ray, you have an MRI. Which one would you start with in this patient?
You start with an X-ray.
Exactly. So you start with X-ray. So let's see the X-ray, and Fatma, I would like you to read it. This is the X-ray of this patient. So what do you see? Okay, so start with if this X-ray is normal or this is abnormal, and tell me why it's abnormal. What is the abnormality?
There are some patchy, some patches of white on the left side, left lung area.
Okay. There is more than patchy white things. There is something circular. Do you see it?
Yes.
Okay, what do you call that?
Is it something like a Gauss focus, like something of that sort?
No, gone focus, they usually very white, but that is a cavity. Okay, so that what you see here is a cavity. Okay, so now you have a patient with 2 to 3 weeks hemoptysis and cough with weight loss and night sweats, and you have a cavity in chest X-ray. Okay, so what things now that you are thinking of in the differentials? What further investigations you would like to do to this patient? So what are the which diseases can give you this chest X-ray? Fatma, which disease can give you this chest X-ray? Which infection?
I'm not really sure. Can't think of anything.
Okay. No, it's okay. So TB is one of the things that you need to rule out when you see this chest X-ray. Remember, a cavity in the chest X-ray, you need, when you see this, you need to screen for TB. You need to check for TB, okay? Always, in every patient with a chest X-ray with a cavitary lesion, you need to do TB workup, because that's the typical TB picture in this is a textbook feature of TB, of active TB infection. But before going out on through the other investigations, I would like to take a moment and talk about other things that can present in chest X-ray. So what if the patient has a chest X-ray that showed a patch? So you have a chest X-ray and you have a consolidation. That will give you what would that be? What is the diagnosis in that case? If you have a consolidation.
Could it be something with pneumonia?
Exactly, that is pneumonia. Okay, so if you have a chest X-ray, that is normal, and the patient presenting with very acute hemoptysis and shortness of breath and tachycardia and chest pain. What is the diagnosis in that case? Pulmonary embolism. So in patients that if you have a normal chest X-ray and you think that the patient has an acute picture of hemoptysis, that could be pulmonary embolism. If you have an air fluid level in a chest X-ray, what would that be, Metha?
Lung abscess?
Exactly. So if you have an air fluid level, that is lung abscess. Okay. So if you have a cavitary lesion, that could be TB. If you have a mass, then that could be cancer. So okay, you have this patient, you have seen a cavity in the chest X-ray. What further test you would like to do?
Sputum culture?
Sputum culture. Okay. Which organism are you going to look for? What specifically you would like to ask the lab to do? Would you just ask them to do a regular sputum culture?
No, I would look for acid-fast bacilli. So
Exactly. So you'd like to do an AFP smear as well as TB culture. Okay. So in every patient you suspect TBN, you need to do 3 things. So 3 investigations for every patient you suspect TB in. What are the 3 things? The first thing is AFP smear, acid fast bacilli smear. You need to take sputum from the patient to do a smear and cultures to the sputum. So now when you ask the patient to do a sputum, when do you want to take the sample, and how many samples you would like to take?
Early morning, I think, and maybe
Yeah,
3 samples.
exactly. So 3 samples, one of them at least should be early morning, and each one, those 3 separated by at least 8 hours apart. So that's the protocol for doing sputum culture in patients with TB. The other thing is you would like to do, as we said, smear and culture. The last thing is you need to do something called nuclear amplification test. Okay, so it's a PCR basically. So why you need to do a PCR for microbacterium? I don't think you heard of this before. They didn't teach us this in the medical school, but that is very important and that is very used in hospitals now. So why do we do PCR for microbacterium for TB?
Is that the same thing as the quantiferon assay, or it's a different thing?
No, that's a different thing. Okay, so let's talk about PCR. So basically, PCR is you have a DNA, or you have a nucleic acid, and then you make sure that it's like you want to know what is the nucleic acid that is there in the sputum. So the NAT, or the nuclear amplification, nucleic acid amplification test for TB, is really specific for Mycobacterium tuberculosis, and it is very sensitive, and it can determine if the patient has resistance to medications or not. So you do it for a couple of things. The first thing is to know if this patient has a TB in a very short amount of time. You get it within 2 hours. The second thing you need to know, or it will help you to know if the patient has resistant TB or not. The third thing, it will help you to know if the patient has TB or any other microbacterial disease. So we have microbacterial tuberculosis, and we have microbacterium with microbacterium, for example, other things that are not tuberculosis. For example, Mycobacterium avium intracellulare and other microbacterial bugs. So basically, the amplification test, or the PCR, is very specific to Mycobacterium tuberculosis. They are not specific to other things. While the smear will only stain with fast acid stain. So it will stain every microbacterium is there. So if you have a patient with positive smear and negative PCR, then that patient does not have any active TB. The patient has non-tuberculous mycobacterial disease. And that will help in management, because the management is totally different. Okay, that is maybe some advanced for you, but this is the basis for the PCR test. So okay, so this patient PCR was positive, smear was positive, and the culture was positive. So just you need to know that the PCR, the cultures will take long. It will take around 8 weeks. That's why when you do cultures, you don't wait for the cultures. If you suspect really TB and the smear is positive, the PCR is positive, you start treatment, but you still do the culture. Okay.
Excuse me, doctor. What about the skin test, that tuberculin skin test you can do for TB, right? Do we have to do that?
I'm coming to that. So the interferon gamma assay and the tuberculin skin test, those are used for screening only, which means there is a patient who is healthy, who does not have any symptoms, A patient that is not even suspected to have TB, we do that. We do a screening for this patient for the sake of employment or visa renewal. So it's not to know the cause of a patient's symptom. It's just a screening. So that is when you do tuberculin skin test, or you do an IGRA, interferon gamma release assay. So which one is better? Usually we say that the IGRA is better. They're same. They are the same in a patient who are not vaccinated, but in a patient who is vaccinated, like most of us, that in those category we do IGRA, because tuberculin test can react to the vaccine. Now that leads us to another point. When do we define active TB? So I don't want to give you a lecture on TB, but so if a patient has if a person, healthy person like me, have a positive screening test, so has a positive tuberculin test or has a positive interferon gamma release assay test. So what do you do next, Meitha or Fatma?
Then I would take a chest X-ray and get a sputum culture. And
Exactly. So the first thing you would do, then you would do a chest X-ray. If the chest X-ray was normal, then that patient is defined as latent TB. So you will treat for latent TB. Okay. If the chest X-ray was abnormal, then that patient has an active TB. You would treat as a patient, this patient as an active TB. You would send for the sputum smear and culture and PCR, and you treat as an active TB. Okay, so this patient has a positive smear, has a positive PCR, and has a positive, cultures will take 8 weeks. So has a positive PCR for Mycobacterium tuberculosis. Now, what would you do? You have the patient in the ER. What would you do?
Do you
What is
start
the
with
next step?
prophylaxis? Prophylactic treatment?
No, you start with active treatment because you have an active TB in this patient. But like before starting the treatment, there is something you need to do.
should we isolate him?
Exactly. So what isolation method you would do in a patient with TB? Which specific isolation method?
Is it a pressure room or a negative?
Yeah, exactly. A negative pressure room, and you would use a N95 mask when you go to see the patient. Okay. So now you start treatment. So what treatment you would give for a patient who has a TB which is non-resistant? Okay. Non-resistant tuberculosis. What are the treatment methods? What are the treatments?
Rifampin, isoniazid, pyranozamide, and ethambutol. Is that the one?
Yeah, exactly. RIPE. Okay, the treatment is RIPE. R for rifampin, I for isoniazid, P is for pyrazidamide, and E for ethambutol. So you give that for this patient for total of how many months?
2 months.
You give 4 drugs for 2 months and 2 drugs for 6 months.
Oh.
Okay, so you give all 4 drugs for 2 months, then you continue with rifampin and isoniazid for 4 additional months. So the total treatment period is 6 months. Okay, and usually you keep the patient in the hospital in isolation until there is a negative smear. So you repeat the smear every often, and then you see if when the patient has a negative smear, then that patient can go to the public. Okay, and you make sure that they take the medications, and that's it for TB. Okay, so that's really the case. This patient was treated, and that is really the case. But I would like to add like a few things when you approach a patient with hemoptysis. So basically, the first step in approaching a patient with hemoptysis is making sure that the patient has a hemoptysis. Then the second step is what? If the patient has hemoptysis, the second step is to identify the quantity of bleeding. If the patient was having a massive hemoptysis, you would intubate the patient and then you would call the ICU to see the patient. If the patient was having non-massive hemoptysis or mild hemoptysis, small amount, then you would do a chest X-ray. Now, after the chest X-ray, if the chest X-ray was normal, what do you do in patient with hemoptysis? If a patient young having a negative chest X-ray, the history is not very typical for PE or any. You don't think the patient has any serious acute condition. What would you do? A patient with hemoptysis with normal X-ray.
You suspect a pulmonary embolism?
Okay, so the embolism, you don't think that this patient has PE. He doesn't have acute hemoptysis. Hemoptysis has been there for a week. So in those patients, young patients, healthy patients with normal initial investigations such as X-ray and labs, what would you do? You would treat the patient as outpatient. You would consider that this is maybe related to bronchitis or some viral infection. You will follow up the patient. That's it. If the patient after follow-up is still having hemoptysis, then you would go for CT. But if the patient has a negative, if the patient, the X-ray was abnormal and did not relate to any infection, so that the X-ray showed some non-specific findings like ground glass opacities, or the patient X-ray showed a mass, or the patient X-ray showed some hilar opacities. So something non-specific, you would do a CT scan. If the patient has a very specific finding like this patient, he doesn't need to do a CT scan because we really know the cause. Okay. So I think I would stop here. Really, hemoptysis has a very long list of differentials, but that's basically it. We covered most of them. So do you have any questions?
Okay, thank you all for this informative and insightful discussion. We will open the floor now to the audience to share their questions and comments in the chat box.
Okay, so there is a question. What if it was latent TB? How would treatment differ? Okay, so this is not latent TB because latent TB does not present with symptoms. Latent TB only presents when you do a screening test. Otherwise, it is asymptomatic. If it's symptomatic, then that is not latent TB. How would treatment differ? Yes, treatment is different because in active TB, you start with 4 medications. In latent TB, there are many approaches. So basically, you can use only isoniazid or azide with rifampin, or there are many regimens for treating that. That is, you can look that up and up to date, see what other regimens there are that are there. One more point I need to add just before finishing this: every patient with TB gets a HIV test. Okay, every patient with TB, you do a HIV test because HIV increases the risk of having TB significantly. So this patient we did the HIV test for him and it was negative. Okay, but you need to keep that in mind. Okay. Any other questions?
Okay, I think we can conclude today's session. Thank you, Dr. Abdullah. Thank you, Metha and Fatma, for this comprehensive discussion. It was very enlightening. I would like to thank the audience as well for attending today's episode, and we hope we meet you all again next week. Thank you.
Yeah, thank you for this chance, for this opportunity to give to share the case with you, and don't forget to get the vaccine. And see you later.
Thank you, Dr. Abdullah. It's always a pleasure having you with us.
Yes, thank you so much. We really appreciate
Welcome.
it.
Welcome.